Next, I'm happy to introduce another round of two keynote speakers, Sydney Whiteford and Connor McKinney from IU Prevention Insights. Sydney Whiteford is a public health expert with experience as a technical assistant provider, public health consultant, epidemiologist, behavioral health promotion. Sydney received her master's in public health from the University of British Columbia in Vancouver, Canada. She specializes in assessing community needs, data analysis, data visualization and utilization, health equity efforts, as well as outcome evaluation. She delivers culturally competent, comprehensive support that helps state and community level programs address system-wide issues, incorporate evidence-based practices, monitor progress, and support staff in achieving program goals. Sydney's recent TA experiences include serving as the internal TA strategist, addition to providing support to SUPTR, CRSA implementation and older adult grantees funded through the State of Indiana's Family and Social Services Administration Division of Mental Health and Addiction. She worked previously as a substance use prevention epidemiologist with the Indiana Department of Health and as a prevention specialist with a local level HIV substance use prevention grant. Joining her will be Connor McKinney. Connor McKinney is an experienced technical assistant, provider, public health consultant, applied researcher, evaluator, and an expert in behavioral, social, and community health promotion. Connor received his master's in public health from the Indiana University in Bloomington. He specializes in assessing community needs, theory-based program design, strategic planning, mixed methods evaluation design, and implementation, data utilization, and grant writing. Connor's recent TA experiences include serving as a lead TA overseeing the older adults grant, in addition to providing support to SUPTR, CCRSA implementation, and older adult grantees funded through the State of Indiana's Family and Social Services Administration Division of Mental Health and Addiction. Connor is dedicated to providing culturally competent, comprehensive support tailored to each individual community in order to build their own capacity to address local needs and to influence positive health outcomes. Please welcome Sydney and Connor.
Okay, good afternoon, everyone. As we were so warmly introduced, my name is Sydney Whiteford, and my co-presenter is
Connor McKinney.
And we are technical assistant specialists with Prevention Insights at Indiana University. And today we're going to be covering unearthing data gold mines, navigating sources and strategies.
So something we like to do for any presentation that we'll give is start with a land acknowledgement. And so as you can see here, we would like to acknowledge that the land that we are gathered on today, now known as Indiana, is the traditional, ancestral, and unceded territories of the numerous indigenous peoples, including the Miami, the Potawatomi, the Piankashaw, the Wee, the Kickapoo, and the Shawnee people. We would also like to acknowledge that all of you are joining us from near and far, and we would like to recognize the traditional owners and caretakers of those lands as well. So today has been so far a great opportunity of looking at what the state of federal data is showing us on a lot of substance use problems and issues, as well as state data. But as Sydney alluded to, we are technical assistance providers, and we more so work on the community level, really helping communities around the state address local issues. And so through our presentation today, we're going to kind of take a step back and examine what we're seeing at the community level. And so really to get us started, we're going to take a look at broad categories of data that we're seeing being utilized by local coalitions around the state to really address those local issues.
And so when we're thinking about those data pieces, there are four main broad, as Connor said, categories. We see demographics, determinants, which includes those risk and protective factors, consequences, and outcome data. And so with each of these, we're going to break down kind of what the working definition tends to be for the sites that we're working with, as well as common examples of the types of data that they're pulling, as well as what their usual sources are. So we begin with demographic data. We know what that is, information about groups of people according to certain attributes. So we have age, sex, place of residence, your basic level data. The biggest one is always the US Census Bureau, which I'm sure is no surprise to anyone, but we do also see sites pulling data from the United Health Foundation's Americans Health Rankings, the IPRC regional data, as well as Data USA. And it's worth mentioning that these sources are not an exhaustive list of where all of our sites get data. However, these are just the most common places that they are getting data.
So the second broad category that we really see utilized are determinants data. And as you can see here, the determinants of health are what include the social and economic environment, the fiscal environment, and then a person's individual characteristics and behaviors. And so this can include the risk and protective factors, which influence how likely someone is to experience an adverse health outcome. And the one caveat we will provide here, and we'll provide a little bit more resources, is how you can solve this caveat later on in the presentation, is actually for the non-majority populations, determinant data is often a lot harder to find. And we see that around many communities, both rural, urban, and suburban. Some example points that you can find through determinants data, as you can see here, I won't read them all, but predominantly we're looking at like median income, access to health services, and those pro-social involvement opportunities. And then down below, again, the Census Bureau pops up, the Indiana Department of Health, and then the health rankings is, again, as some of the predominant site or sources that we're seeing our sites use to find this data.
The third most common type of data are consequences data. So again, this is the tertiary impact that the health issue has on the community at large, especially within a legal, clinical, and criminal justice setting. The common ones that we see are hospital discharge rates, school suspensions related to a health issue, mental health service use, arrests and citations. And the SEOW has actually been a great source that a lot of our sites use, especially the data dashboards. And again, you'll see some similar trends with common sources popping up again.
And then lastly, the final broad category will cover our outcome data. And so as you can see, health outcomes are the interrelated set of attributes that describe the impact of a health issue for an individual. Some example points that our sites are using as they're looking at outcome data would be the mental health diagnosis rates within their county or community, drug overdose deaths, and e-cigarette use, just to name a few that are up here. And again, some of the sources that they're going to find these, again, we have the SEOW reports dashboard, and then as well as the National Center for Drug Abuse Statistics. Those are the two predominant sources that we're seeing.
And so the final piece that we've gotten so many wonderful examples of today here at the symposium is the importance of comparative data when they're gathering all these different types of pieces. So we really try to impress upon sites, and what I think they have a really strong understanding of is that it's not enough just for them to pull data for their specific community. They also need to be able to find the same exact data points at a state and national level. This will provide more weight to the arguments that they're making that there is something different happening in their community, and this is able to quantify that. However, even though we instill within our sites and they understand this comparative data is important, that doesn't mean it's easy for them to find. Usually state and national are a little bit easier for them to navigate. However, when it gets to that community level data, this is where they really struggle to be able to find these different pieces to bring this story together. And that is exactly what we're going to talk about next. What are the things that we, Connor and I, as their TA providers, as well as other people they're working with across the state, try to encourage them to do in order to solve these data gaps?
So as Sydney alluded to, oftentimes we know that it's more difficult to find specific data related to the issue that you're trying to address within your local community. Oftentimes our sites have no issue finding what the state level is or what the federal level is on an issue, given maybe like, let's say, past 30-day use of alcohol for those between the ages of 12 and 15. Oftentimes that's a lot easier to find at a national or a state level. But when you try and look in your community or you're just conducting an online search for local data, that's where we see a lot of the difficulties. And so what we will suggest to our communities is really utilizing some local quantitative and qualitative data to fill in those gaps and provide some more of that community context that they're looking for. And that's what we're going to focus on this part of our presentation. We're going to really start with some of the quantitative efforts that we see, because oftentimes this is where you'll want to start to get those raw local numbers, and then you can kind of supplement that with the quantitative, providing some of that perspective and community context afterwards. However, we'll start with surveys as the first quantitative method that we see used predominantly by our sites. And the neat thing about surveys is they can be both quantitative and qualitative. However, if you're focusing on the quantitative side first, as you can see here, is one thing to keep in mind is you really want to keep your questions closed-ended. So making sure that you're using scales, multiple choice options, or simply yes, no choices. And then, like I said, you can supplement these quantitative questions with more open-ended qualitative questions, either at a later point or even later on in that same survey. So predominantly, looking back at the broad categories that we've already discussed, our sites will use surveys primarily to look at demographics in their local area, determinants, and consequence data if they're trying to fill in some more of those gaps. And some of the primary locations that we see our surveys used, one that's really popped up here in the last few years and has really taken over our geofencing options. And we'll see that primarily at our next stops here we're geofencing around places where a large amount of the community will gather. So for our older adults, we'll see them geofencing at religious gathering spaces or assisted living centers. And for our families or for the younger youth that we're trying to survey, that's more so at like grocery stores, local parks, places where they're going to congregate. So the second quantitative data collection method that we'll see used by sites are observations, and specifically identifying the specific behaviors, services, events, or outcomes of focus, and then just documenting the number of times that those are observed. We'll talk more about qualitative observations in a few slides, but again, that is better to use to add context to the number of things that you're observing within your community or within the specific area of focus. And so predominantly we see our sites trying to use observations in this form to look for determinants or more so of those consequences that they're seeing within their community. So two examples that we see a lot are windshield or environmental tours and scans documenting, for example, the number of alcohol retailers in a community, or even documenting the number of grocery stores available per 1,000 people if you're trying to find out more about the social determinants of that area. So moving then into our qualitative options, what we really see our sites start with when they're looking at qualitative are these individual interviews, finding those community champions and just trying to get some information out of them that can really help to add that community context. And when you're looking at individual interviews, we have three major options to go with. So you can start with a structured interview if you're looking at that option. This is when the same amount of questions in the same order are asked of everybody. From a top-down view, this can seem like the most reliable form since you know that the interviewer is asking the same questions in every interview in the same order. However, this can often make the interviewee a little bit more nervous as this predominantly sets the interviewer above the interviewee, and there's kind of that dynamic struggle throughout the interview sometimes and can lead to them providing not necessarily false answers, but maybe not the full truth if they were more comfortable. The second option are semi-structured. So similar to the structured interview, the same base set of questions are provided. They just may not be asked in the same order. And this also allows for more follow-up that may not be asked in other interviews or in the same order at that. This does lead to a little bit more being sidetracked. However, this really starts to break down that differentiation between the interviewer and interviewee and moves a little bit closer to a more natural conversation, like we'll see with an unstructured interview. So with this, the interviewer is provided a list of questions that they could ask. However, they're not required to ask each of those questions. And there may be questions that are not on the list that get asked as follow-up that are not asked in other interviews. This is supposed to be more like a less formal interview and more like a natural conversation. However, from a top-down view, this one can seem to be the most or least reliable and most open to getting sidetracked. So as I said earlier, we have both quantitative and qualitative observations. And so the main difference we'll get into in a second that sets this apart from the qualitative. But as we're looking at quantitative observations, we have two specifics that we see a lot of our sites utilizing. Starting with direct observations, this is just about examining places, people, or activities without directly interfering or taking part in what's going on. And then on the other side, you have participant observations, where you're more involved in the actual learning, the taking part in a community's culture celebrations or everyday activities. The caveat we will give with this is that this is oftentimes conducted by a member of that community, a local champion, somebody that is very engaged just with the comfortability that's required and to be kind of welcome into a lot more of these intimate settings and cultural engagements. So as we're looking at what data we can collect through a qualitative observation, you're really looking more so at taking note on the physical characteristics of that setting, describing or providing a description of the people that are involved as opposed to the number of people involved, really taking a description of the activities, events, or places that you're observing, taking note of the nature of interactions that's happening there, and then also capturing people's apparent attitudes towards the place, the situation, or activity that you're observing. So again, the differentiation mostly is with quantitative observations, you're just counting the number of things that you see, the number of times you observe them. Whereas with the qualitative side, you can go more in depth as to what's happening around those numbers.
And I will say in terms of practical application for the sites, that qualitative data collection methods are more frequently used when they're trying to target specific populations. And we're really trying to understand what a specific group of people needs. It tends to allow for more tailoring, more creation of a safe space so that more honest answers are shared.
So at this point, whether we're working with sites to either begin their data collection process or start their own development of tools in order to collect the data, they'll eventually get to a point where they have this just abundance of data and they really don't know then what to do with it at that point. And so a lot of the suggestions and work we do with our sites is to help them piece these bits of information together to really drive home that the decision making should be informed by what the data is telling you. But at the same time, that's not where you should stop using your data. And so as Sydney will get into, we also have recommendations on how you can take that data, put it into bite-sized forms, and really spread it throughout your community.
This is a picture we often use when we're talking about this with our sites to appeal to people who are visual learners, I myself included. So we go with the Lego metaphor just to show them that you get to this point where you know all this data is out there, that very first giant unsorted pile of Legos. And then when you have a better understanding of the types of data that you're looking for, you can begin to put them in neatly sorted piles. And finally, as you have narrowed down, these are the specific pieces I'm interested in, you're able to start arranging it in a way that makes a little bit more sense. And where we've arrived now is working with the sites to teach them how to present it in a way that visually makes sense, as well as can be explained into a broader story which has more impact. And so what we really try to impress upon them is that it's worth it to take the time to refine all of this data that you have found. So we know, because you are the person who lives and works in the place that you're trying to do this work, that you have a strong understanding of what the problems are of your community. However, for someone who's never even stepped foot into your community, pulling in quantitative data like this can help assign numbers to the gaps that you see. And this can make an even more compelling case for why resources should be allocated to the place that you live and work. We also really try to encourage using data visualization beyond just putting it in future funding applications, but trying to work it into different parts of the work that you're doing, which we'll get into in a future slide. But overall, we really just want them to go beyond just having this pile of data and sitting on it or only putting it in an application, because data is something that can be harnessed to showcase successes, challenges, and your continuing growth for capacity. And so one of the really big things we hit on is show and tell. So when our sites want to share data, we want to make sure that they aren't just making a graph or telling people what the data says. We really want them to use both. So we have some common examples that we show them. We have this graph here that we think is a good example where not only are you trying to model how many of all drug overdose deaths can be attributed to opioids, but you're also telling them with just a brief sentence at the top. We want to make sure that data is easy to navigate, and we want to impress that upon the sites as well. We usually show them a subsequent example like this. It's a little bit more simplistic, but it's again putting some data visualizations to the point that you're trying to make. For the case of this example, that while opioid overdose is increasing for both males and females, males have a higher rate of opioid overdoses. And so we also really encourage them to share their story far and wide. We do not want them to limit all of this data that they're collecting, which we know is rich and very in-depth, to just future grant proposals. And so they've done things like work it into community newsletters, put it into social media posts. One event that we've seen sites have a lot of success with is data and donuts, or some food variation of that, where we get people in the door with a sweet treat, but then we use that time to come together as a community and talk about the data that we're finding. We also really encourage them to not data dump if they can't get people in the door or to listen to data, and instead, as Connor said, break it down into bite-sized pieces. A common example that we use for that is showing this data visualization from IU Health. during the height of the COVID-19 pandemic. This is one piece of data. It's talking about the vaccination status of people who were hospitalized, but even with that one piece of data, you can tell a really rich story and in a compelling way.
So I know today has been a lot of looking at, again, what the federal data is showing us, what state data is showing us. And at times when you're starting your own search, looking for data can seem very daunting. And so really what we just want the takeaways today to be are there are ways to sort out what you're looking for, and that data is ultimately your friend and not your enemy. Data-driven decision making is also what's going to make the true impact that you're looking for within your community. And so once you've got that data, like we talked about with that picture on the Legos, is then sorting it into those groups, putting that story together, and using that to drive your focus, your vision, and your initiatives moving forward. And then lastly, just finding ways to work that data into your current work. Once you've got that grant application done or that evaluation report done, don't just set that data on the shelf. Find ways to include it in your messaging campaigns. Find ways to put it in pamphlets or flyers that get handed out at events or around town, just to better spread awareness around the initiatives that you're really trying to work towards.
And with that, we'd like to open it up to questions. I know some of the sites that we work with are in the audience today. If you have any examples too that you'd like to share about how you grew your own data in your own community, you can share that as well during this time. Thank you everyone for listening. One of the big things that we stress when they are collecting this data that they do not collect any identifying information. So there's no name that's filled out, no birth date, no nothing like that, and that they're using it in an aggregate setting. So they're not breaking it down into individual responses. This is obviously more at the quantitative level, a little less with qualitative interviews and stuff like that. But that they keep it together in one big group to avoid that. And then also they're not going to then use it to inform future research projects or anything like that. It's more so within the context of trying to release a read on what the community's attitudes and beliefs are in that moment for funding applications, things like that. I think you had something additional you wanted to say.
Yeah, so a lot of times when with the communities we work with, it's the data that they're collecting oftentimes isn't sensitive. And so when we're looking more at the broad community level, we're looking more so at just community norms, looking at prevalence of substance use. And so oftentimes also, since it's not a requirement, I think that gets around a little bit of the structure that you need because it's a volunteer opportunity. And like Sydney was saying, we encourage our sites to not collect that identifying data. Now, through the grants that we work with, there are some times where identifiers are needed. And so we will work with our sites to create not nonsense identifiers, but kind of just ways to identify somebody without directly identifying them. So there is that track back, but not kind of getting out any of that sensitive information. Well, we have one last slide. It's just if you are interested, we have some socials that we have resources and things that you can go and locate. They have, we have our IPRC training portal, which we also highlighted earlier in the slide, that has training opportunities and things like that if you're ever interested in following up with any of this.
Thank you so much.
Thank you, Sydney and Connor. Next, I have the luxury of introducing my colleague and dear friend, Mr. Jason Collins from Cyber Health. Jason Collins is an experienced public health epidemiologist specializing in infectious diseases. proficient in data visualization using quantum GIS systems, creating interactive dashboards, informed decision-making, and trend identification. Ladies and gentlemen, please welcome Mr. Jason Collins.
All right, good afternoon, everyone. Again, I'm Jason Collins. Thank you very much, Malcolm, for that wonderful introduction. So I'm going to go ahead and be taking some time to explain a little bit about the CASA, this Community Addiction and Assessment Services. And I'm going to start a little bit with the background of this, but really with us at Tower Health, we are kind of been partnered with DMHA to really kind of find some of these data sources, being able to find some literature surrounding this, the available services, and being able to utilize the reports, the work that's been done by some of the other organizations around, and put it all into one report, kind of compile that together and look at what those insights can bring us. So in September of 2022, the Indiana Behavioral Health Commission released a report on the state of the Indiana behavioral health system. And this report was really outlining several key recommendations for improvement. And one of those primary recommendations was really to utilize this 988 National Crisis Line as a mechanism for really developing a state crisis response system. So this would be so that individuals that were experiencing mental health crises would have that 24/7 access to support and their resources. Another recommendation that came out from this was that we could start to transition Indiana's community mental health centers to federally supported certified community behavioral health clinics, or CCBHCs. So these CCBHCs are really supported through grants from Medicaid, as well as the Substance Abuse and Mental Health Services Administration, or SAMHSA for short. CCBHCs provide comprehensive, integrative behavioral health services in the form of 9 distinct services. And that is inclusive, but not limited to your crisis services, your peer family support and counseling, your outpatient mental health and substance use services, and risk assessments, just to name a few of those. And really, CCBHCs have been required to do several things. So one of the things that they must do is operate 24/7, so 24 hours a day, 7 days a week. They have to provide comprehensive care and services so that patients don't have to go ahead and kind of piece together the needed treatment that they need, go through multiple hoops and go to multiple providers to seek what they need. And they also do have to provide care coordination in order to help those patients with being able to navigate these multiple sources and services that they're using. And then they are also required to provide services to those that are requesting for mental health or substance abuse related care, regardless of their ability to pay. The commission also emphasized the need to increase public health services and interventions within the criminal justice system, and they had proposed establishing a Medicaid waiver that would allow for federal reimbursements for services provided to incarcerated individuals. To address the workforce challenges posed in Indiana, the commission was recommending specific types of measures to improve recruitment, your retention, the quality of behavioral health workforce. And these measures would really be about reducing the barriers to licensing, providing tuition reimbursement programs, and also being able to do this to really attract and retain those qualified professionals within that field. And additionally, the report was highlighting the need to further explore the availability of youth services. This would be inclusive of those assessments and of these current programs, and identifying those existing gaps to really ensure that the Indiana youth have access to the mental health services that are needed. Finally, the commission discussed the potential funding options for proposed systematic changes as well. But overall, what we're seeing is that from the Indiana Behavioral Health Commission's report, it was there to really provide this roadmap for enhancing the state's behavioral health care system, addressing both current challenges and those that will be later on identified in the future. And these recommendations are really these crucial steps for being able to go towards a more effective and accessible and comprehensive behavioral health care system within Indiana. So for the CASA model, building on these recommendations from what we just discussed previously, SEOW is using the Community Addiction Services Assessment, or CASA model. And the CASA model is used to assess the current state of your addiction services, identify any types of gaps or areas that are in need of improvement, areas for opportunity, and also provide actionable recommendations to enhance service delivery. The model is essential because it is aiming to serve as this organizing framework for your state agencies, for policymakers, for practitioners, and to evaluate and enhance these various components of the Indiana Addiction Services System, or IASS. This is really within itself a statewide network of addiction resources and services that have programs to provide for assessments and then for cultural competency and sustainability, and they are based off of SAMHSA's Strategic Prevention Framework, or SPF, which is composing of these 7 steps, which we're kind of seeing here, and I won't name them all. But again, cultural competence, sustainability, and these steps are really there to help in that evaluation process of evaluating existing community resources and then those opportunities for further improvement and for intervention as well. So within CASA, the model evaluates 9 specific addiction service domains. The most recent version would be the SEOW Special Topics Report number 4, which will be mostly covered for today. And this would be on the first 2, which are the assessment and the prevention services. So for the assessment domain, this is really using several key surveys. There was several key surveys that were used to gather this essential data on mental health and substance use trends within the state of Indiana. And this would include surveys such as, but not limited to, things from the Indiana Youth Survey, like INYS, the Adult Gambling Behaviors, Indiana Survey, and the Adult Tobacco Survey, and so on and so forth. But each one of these surveys, they were used to really help understand the needs of different populations and to develop this targeted intervention as well. When we look at the prevention domain, this is really more so including all of the state and federal addiction resources, those services and programs that are really aimed at preventing substance misuse. So this this would be program and resources, drug-free community coalitions, your local coordinating councils, your school-based regional preventional providers. And for the CASA model, what we're really looking at is trying to provide this robust framework for being able to evaluate and also being able to enhance the addiction services in Indiana. And this would be done through systematically assessing the current services, being able to identify gaps, and then making those evidence-based recommendations so those improvements can come to better get the Indiana Addiction Service System to better support individuals and their communities by improving their substance misuse programs. Okay, so for, again, the assessment domain surveys, and we briefly touched on this in the previous slide, but the assessment domain features 6 key surveys that collected data on mental health and substance use trends in Indiana, and this was across various populations. So these surveys, such as, again, INYS, we have our Indiana Youth Survey, our ICSUS, ITS, and AGBI. So these first 4 were selected as measures for the CASA model because they were really all specifically related to Indiana mental health and substance use abuse trends, as well as being locally funded by Indiana FSSA. So the adult tobacco survey is actually administered by the health department, Indiana Health Department, rather. And then we have WIRE-BS, or the Youth Risk Behavior Survey, and this is administered by the Centers for Disease Control, and this is used to track those behaviors that can have an impact on health in high schoolers. So they're doing this for 9th grade all the way to 12th grade. And they're looking at variables such as sexual behaviors, your substance use, individuals that had experiences with violence or mental health or suicidal thoughts and suicidal ideations as well. And to briefly touch on the adult tobacco survey that was released in 2022, the results had found that almost 29% of adult Hoosiers had used tobacco, with those combustible cigarettes being the most common, but also very closely followed up by the e-cigarettes or the electronic cigarettes. And there were notable disparities with tobacco use across the populations in different groups, which found that households with lower income and then individuals that had a history of mental health or substance uses were more likely to be using tobacco products as well. But the research also did highlight the popularity of flavored tobacco, particularly when we're looking into younger adult populations, and then exactly how much these flavors can actually mask that harshness of tobacco. And 85% of those individuals that were e-cigarette users had actually reported using those flavored products 30 days prior to taking that survey as well. However, in that year, from the 2021 to 2022 year, more than half of those e-cigarette users, and then more than over a third of those cigarette users had actually reported having to have made an attempt to quit as well. Okay, and right here, this is a part of the Indiana Youth Survey. And again, this is dedicated to students in grades 6 through grades 12. And this was aimed to identify those regional trends in youth substance use and mental health. The survey did reveal that there were varying participation rates within each region and among the number of students in schools and in corporations. Really, the overall statewide participation for this was just over 15%. So there was wanting to get more individuals to take a part of this. But one of the things that I did want to point out, and I'll go into a little bit more detail later on, but this is something that would be part of the dashboard. So again, this is information from organizations that had done the surveying, and then what we're doing is being able to take this information, and then we're trying to visualize that and put those on those dashboards that we talked about earlier. So we have those SEOW dashboards where we're having the compilation of TED's data, Burford's data, and so on. And then this would be something else that would be in addition to that, where you'd be able to interact with that. You see that there are 3 classes where it's students, and then your corporations, and the total amount of schools, and then you see how many individuals would be in that population. And if you were to go ahead and hover over any one of those regions, then that would show the actual participation rate for that region, depending on what class that was as well. So for the local coordinating councils, and this is moving more so into the prevention domain now. So your LCCs actually operate in 91 of the 92 Indiana counties that we have, and they really focus on providing mitigation in drug-related issues through local planning, your collaboration, and with your local stakeholders and so on. And these councils, what they really want to do is to bring together your local stakeholders, your community, to address 3 core areas. And this would be based on your prevention and your education, your treatment, and your intervention, and also your justice programs and your supports as well. So this LCC approach, what it's used to do is really to ensure that the local knowledge and resources are being utilized effectively and impactively to be able to really tackle your substance misuse issues that are specific to that community. And then a funding for LCCs really comes from the local drug-free community fund that is overseen by the Indiana Criminal Justice Institute. And this funding really supports that development of and implementation of something called a comprehensive community plan. And this is something that outlines the strategies that an LCC will take to combat substance misuse in their area. And to evaluate the effectiveness of that, LCCs are required to submit annual comprehensive plans, participate in those focus groups, and then also being able to provide annual reports and complete surveys as well. And then these are the surveys that we saw earlier when we were more so in the assessment domain. And since we covered this out, I can go ahead and skip past this just a little bit. But going back into the prevention domain here, we're taking a look at the school-based regional prevention providers, and they are very needed in order to deliver targeted prevention programs to our Indiana youth Hoosiers. And these types of providers are actually funded by the state through child psychiatric funds, and are very essential in helping to implement prevention programming in schools and communities. So in 2023, organizations such as Lutheran and Hamilton Center, as well as Youth First, were able to utilize this type of funding to offer prevention services for 44 of our 92 Indiana counties. And their work really focused on being able to equip our youth with the skills and the knowledge that was needed to avoid substance misuse and promote mental health wellness. The programs are offered by these providers include a variety of evidence-based strategies and initiatives. These are designed to really address those unique needs when it comes to various education levels for your students. It's looking at providing needs for health education, for life skills training. You're looking at peer resistance strategies, and other types of supportive interventions that would be aimed at really preventing the substance misuses and promoting that overall well-being for those students. And then showing here are two maps. On the left, we have a color-coded map of the counties to show or I'm sorry, uh, on the left of the slide, but to my right. But over here, we have the yellow, orange, and kind of brownish counties, and this is showing the program. So if it's Lutheran, Hamilton, Youth First, where they are exactly located within the counties. And then if we see in the legend, part of that 44 counties overall, we get to see what the actual aggregate is of that. And then the map here on the left is kind of a copy of the first one. So we're still working with the same counties, but instead this is based on a program strategy. So, is that a strategy that's targeted to the community? Is it for the school and district, or does that somehow have a mix of both of those as well? So this is what these two maps here are showing. And then for the drug-free community coalitions, or DFCs for short, these are federally funded and they are dedicated to being able to provide evidence-based prevention services at the local level. So this initiative was really established as a part of a national strategy in 1988, and this was to be able to really equip communities with the necessary resources to respond to your substance misuse related issues through coordinated efforts. So these coalitions, what they do is they engage with a variety of stakeholders. They are inclusive of your faith-based organizations, your community organizations, your businesses, your schools, parents of youth, and other groups to really implement this effective drug reduction strategies. And as a part of the most recent updates, there are currently 23 drug-free communities coalitions in the state of Indiana. Each one of these coalitions do work with the community to develop and implement programs that are aimed at reducing these substance misuses and promoting healthy behaviors. And they also do focus on building local capacity, really in order to address substance misuse by fostering collaboration and having that be done among different sectors within the community. And then we were also able to derive the different addresses of these coalitions. So you can get these from. There's a link that's provided from the drug-free coalitions in Indiana, but also CDC does feature them since it's federally available. And while we can't download that sheet, we can get the address information. So each one of these dots, they are not just randomly placed within a county. It is actually the true coordinate of that location, and that's something that we always like to do. We just want to give the actual positioning of that place as well. But when we look at this map, one of the things that we can see is that there are some regions that may have more and some regions that may have less, but these could just possibly be more areas for opportunity. And now the Federal Substance Abuse Prevention and Treatment Block Grants, or the SAPT-BG, these are really essential in being able to support a wide range of prevention and treatment initiatives across the state of Indiana. These are also administered by SAMHSA, and these grants, what they do is they provide these crucial financial supports to be able to help communities address the substance misuses and the mental health issues in their community. In Indiana, 20% of these block grant groups are actually designated for prevention services specifically, and the funding is supportive of various programs that are designed to really reduce those misuses and then also promote mental health as well, and that's done on a statewide basis. The programs also do include components such as information dissemination and also education. We're looking at alternatives to drug use and substance use, and then also including problem problem identification and referrals, and then community-based processes, as well as environmental strategies as well. And then in the year 2022, these funds had supported 15 community prevention strategies or sub-grants for odor adult prevention sub-grants and so on and so forth. There are a lot of programs that this went to, but overall, what we see is on a numbers basis, it had served 1.3 million Hoosiers, and that would be inclusive of 136 plus thousand through individual-based programs, and then the other 1.1 million that were impacted through their population-based programs. So right here, we are taking a look at some of the next steps. So one of the things that you had heard in Dr. Devaraj's presentation in the first half of the day is that there are special topic reports that we have, and this is something that takes place through conversations with the SEOW committee to see what items that we need to focus on going forward. So we have completed the first two, which we covered, which were the assessments and prevention domains, but now we also have the remaining domains. So just really working hand in hand with DMH to continue to gather this type of information and making sure that we are able to compile these reports in a way that is comprehensive and really hitting on all of the available resources that we have. So that would be inclusive of, making sure that we're able to see what types of services are being provided, making sure we can get more, more maps and more visualizations to try to find out where those gaps are as well. And then if I can direct your attention back to here. So this is a part of what we were covering in the earlier slides, and what we're continuing to do through our partnership with DMHA. We are continuing as part of this work for SEOW to continue in building these interactive dashboards. So earlier we had the chance to look at some of the data from TEDS, from Burfus, in the form of the charts and the graphs from Dr. Devaraj's presentation. But we're also wanting to make sure that we're really hitting on the mapping efforts too. So we have the ability to show, where these programs are, whether it's the block grants, whether it's your drug-free coalitions. And when, let's say, if you were to log into this and you were to hover over those, and you would be able to see from the DFC side the actual name and location of that place, and you would be able to just have any other interactive features along with that. But what we're doing is really making sure that we can leverage the information and the tools for the geographic information systems to make sure that we are creating additional maps and additional visualizations based on what we're finding and based on the available resources to show the availability as well as the spread of these services. So again, we are able to look at these kind of on a class-based or color-coded or sometimes chloropleth maps, depending if we're working with numbers and rates, but then also we're also to do more so like dot density maps to see which areas are maybe lacking or maybe where there's areas for opportunity and growth. And as we continue to get data, we will continue to update, and that would be the same for any other dashboards that we have too. So as new data comes, we continue to update and work hand in hand with DMHA to get that done. Well, I would like to say thank you very much, everyone, for your time and for your attention. This would conclude my presentation, and I am happy to take any questions. Thank you. Yeah, so it's okay to contact either myself or Dr. Devaraj for the dashboards. Yes. Let's see. I have my glasses off for today, so I might need some help. Let's see. Yeah, so these ones are all colored in. I can get back to you on that after the after my presentation, if that's okay. Any other questions? All right, well, seeing none, I would just like to thank everyone once again for your time and for your attention, and looking forward to the presentations coming up. Thank you.
Thank you, Jason. I now have the luxury of introducing a fellow Boilermaker as well as my old classmate from Purdue, Ms. Shelby Neerman. Shelby is the Data and Outreach Equity and Surveillance Lead in the Office of Data and Analytics at the Indiana Department of Health. Shelby has had extensive experience utilizing Indiana's statewide syndromic surveillance system, Essence, to monitor for spikes, clusters, and anomalies in overdose-related ED visits as the overdose surveillance systems epidemiologist at the Indiana Department of Health for over 2 years now. Shelby graduated from Purdue University in 2019 with her Bachelor of Science in Family and Developmental Science and received her Master's of Public Health from Purdue in 2021. Shelby is passionate in her efforts to engage with local, state, and national leaders to address public health issues, transform data into acknowledgeable insights, and deliver impacts to improve the health of all Hoosiers. Everyone, please welcome Shelby.
Great. Hi, everyone. My name is Shelby Neerman, as mentioned, and I'm the Data Outreach Equity and Surveillance Lead at the Indiana Department of Health. And today I'm going to be talking with you a little bit about overdose surveillance and how data systems inform public health response. So our mission at the Indiana Department of Health is to promote, protect, and improve the health and safety of all Hoosiers. And our vision is that every Hoosier reaches optimal health regardless of where they live, learn, work, or play. All right, so I'm going to go a little bit into some of our substance use and overdose data, and I know we've talked a lot about that today and touched on a lot of different data points, so I'm hoping that you'll be able to find some insightful information from this as well. So the evolving nature of the opioid epidemic in Indiana has come in 3 distinct waves. The first wave began in the 1990s and early 2000s as a result of an increase in prescribing opioids, resulting in a rise in prescription opioid overdose deaths. The second wave began in 2010 with rapid increases in overdose deaths involving heroin. And then that third wave began in 2013 with significant increases in overdoses involving synthetic opioids. So since the inception of that third wave in 2013, Indiana has seen the number of opioid-involved overdoses continue to rise. This increase was exacerbated by the COVID-19 pandemic in 2020, and you can see in the graph here that it started to increase in 2020, and then in 2021 it increased again, and we're getting down here in 2022, and hopefully will continue to decrease in 2023 and 2024. Let's see. In Indiana, all age groups have been impacted by the opioid epidemic, but the age group of 35 to 54 has continued to have the highest rate of opioid-involved deaths. And in 2022, that rate was 70.9 opioid overdose deaths per 100,000. So additionally, through even though opioid overdoses have increased for both males and females, we have consistently seen that males are at a higher risk of an opioid overdose in Indiana. And so from 2014 to 2022, the sex-specific opioid overdose rate increased from 9.4 to 50.83 for males, and increased from 4.4 to 24.2 for females. So from 2017 to 2018, overdose death rates decreased in Indiana among all racial categories. However, from 2018 to 2021, another increase was identified among all racial categories, and this increase has especially been notable among the Black and African American population, specifically from 2019 to 2021. You can see that there was a large increase. And as seen in the graph here, the gap between Indiana's drug overdose rate and the national average increased in 2020 and 2021 during the pandemic. The gap highlights the impact that COVID-19 has had on Hoosiers, increasing the risk of opioid overdose-related morbidity and mortality. And while 2022 mortality data is still preliminary and provisional, the gap between Indiana's drug overdose rate and the national average has decreased. And so now I'm going to talk a little bit more about overdose surveillance and how we use surveillance to identify trends in our data. So the Indiana Department of Health utilizes fatal and non-fatal data on drug overdoses in order to recognize overdose anomalies and changes in overdose trends, such as spikes or clusters in counties or some of our hospital facilities across the state. We utilize this data to understand the circumstances surrounding overdoses in Indiana. We utilize it to identify specific substances causing or contributing to overdose. And then we also utilize fatal and non-fatal data to inform drug overdose response and prevention activities, such as increasing the distribution of naloxone and training for naloxone use, or also preparing emerging drug notifications and or preventative messaging to our partners and stakeholders. Sorry, that is very difficult to read, but if you have specific questions about it, just let me know. The Indiana Department of Health Division of Vital Records is responsible for maintaining and issuing certified copies of vital records, including birth, death, and fetal death certificates for events that occurred in Indiana. Death certificate data is used to track underlying and contributing cause of death, to understand the burden of drug overdoses for prevention. The identified overdose cases are based on ICD-10 codes derived from the death certificate information recorded by county coroners or medical examiners. And as I'm sure all of you know, overdose is a sensitive topic, and findings by the coroner or medical examiner may be subjective or under-investigated, so there may be underreporting of overdose-involved cases. And in 2023, there was a total of 2,089 deaths due to any drugs. So kind of what we talked about earlier, we utilize these ICD-10 codes to categorize our deaths or our hospital discharges into different categories. And we utilize the any drug to kind of lump them all together, but sometimes we separate them out to help us gain different insights. But, you know, we've heard today from different folks that sometimes these, from an outside perspective, might not always be accurate, that sometimes these drugs might actually have other things in them. So I think that that is very important to keep in mind here, is that this is what the ICD-10 codes are telling us. This is how billing folks are categorizing these deaths, but that doesn't always mean that it is 100% accurate. And so that's just something to always keep in mind. And so though this data is provisional and subject to change following the finalization of the data, this is a 21.8% decrease from 2022. So that's a really big win for Indiana. And something else to keep in mind here is that when we kind of break these down even further, 75% of all the overdose deaths involved an opioid, and 70% of all the overdose deaths involved a synthetic opioid. And that's in 2023 thus far. Also difficult to read, but if you have questions about it, it's on our dashboard, so you can also look to that. So the Indiana Hospitalizations and Emergency Department visit data are a subset of data that's compiled from the Uniform Billing 2004 form. This data is supplied by the Indiana Hospital Association under a contract with IDOH. And the outpatient or the ED data contains Indiana residents discharged from a non-federal acute care facility who received emergency services without being admitted to the hospital. And then that inpatient hospitalization data contains Indiana residents discharged from a non-federal acute care facility who were admitted to the hospital. In 2023, there were 15,734 overdose ED visits and 5,119 overdose hospitalizations due to any drug overdose. So similarly to our death data, we're categorizing it by those ICD-10 codes. And nearly 35% of all those overdose ED visits involved an opioid, and 30% of all overdose hospitalizations involved any opioid. So the Indiana Department of Health also uses syndromic surveillance to monitor near real-time suspected overdose ED visits. If you've never heard of syndromic surveillance, it is the ongoing collection and assessment of health-related data that is available in near real time, and it precedes diagnosis or lab results, and it allows us to identify sufficient probability that a case or an outbreak may warrant further public health response. IDOH receives electronic health records from our reporting hospital facilities, on average about 3 to 24 hours of a patient's visit to the emergency department, and this data comes to us de-identified through our Essence system. The data is then utilized to monitor and rapidly identify anomalies in visit count and provide situational awareness of changes in suspected non-fatal drug overdose-related ED visits across the state. And because our hospital discharge data must go through data quality checks by the Indiana Hospital Association before being released to us at IDOH, that's often about a 3-month time lag. This data is among our most valuable insight into real near-time data trends on non-fatal overdoses with Indiana, and it is available to both our local health departments and our reporting hospital facilities across the state. And in this graph here, you'll see that over the last 3 years, the number of ED visits captured as suspected non-fatal overdoses, so again, coming in near real time, preceding that diagnosis. So they might have a chief complaint, but they won't necessarily always have that discharge diagnosis confirmed in their record. That continues to increase. There was a very drastic increase that occurred in the second half of 2020 and throughout 2021. And yeah. So together, the Indiana Department of Health utilizes Essence patient records, our toxicology results, our SEOW data, which is our state unintentional drug overdose reporting system, and then syringe service program data to help monitor overdose trends and emerging substances. Altogether, these sources then provide us with a comprehensive view of the current state of non-fatal and fatal overdoses across the state, and then further highlight areas for intervention. So CDC's State Unintentional Drug Overdose Reporting System, or SEOW, provides comprehensive data on unintentional and undetermined intent drug overdose deaths collected from multiple sources. Indiana is one of 48 funded jurisdictions across the state. And we're really excited because CDC does have a SEOW dashboard, and our data was just recently added to that. So go check that out if you're wanting to learn more about this data. But a team at the Indiana Department of Health abstracts data from death certificates, medical examiner and coroner reports and toxicology reports to provide additional details and qualitative data that complements other existing drug overdose surveillance work. So that team at IDOH really sifts through their all of these different death certificates and coroner reports and medical examiner reports and our toxicologies to put together this comprehensive data source. And so we really owe a lot to them because this is a really beneficial source to us when we're trying to really get a good idea of what's happening in real time here at the Indiana Department of Health and throughout Indiana. So the overall goals of SEOW are to better understand the circumstances that surround overdose deaths, improve overdose data, timeliness and accuracy, and then identify specific substances causing or contributing to the death, as well as emerging and polysubstance overdose trends to kind of help inform our overdose prevention and response efforts. And then here, this is provisional, but thus far, these are the most common substances that have been found in Indiana SEOWs. In 2022, 84% of fatal opioid overdoses captured in this data source primarily involved illicit opioids only. That was followed by 11% of fatal opioid overdoses captured in SEOWs involving a combination of prescription and illicit opioids, and 5% involving prescription opioids only. In 2022, the primary route of administration in fatal overdoses captured in SEOWs was unknown, followed by injection, smoking, and snorting. In 2022, 6% of all our SEOWs opioid overdose cases involved xylazine. And again, just kind of a caveat about suitors while we're on this. I'll give you guys some time to look at this graph here. Suitors is captured from a subset of our counties, and so we don't receive the suitors data at any specific time frame. So we could be receiving death certificates or coroner reports or toxicology results months later, or even a year later from when that death occurred. So our data is kind of always updating. So we could receive more xylazine involved overdoses from 2022, and we'll continue to receive 2023 and 2024 as we move along. So our toxicology data is another source of information that we rely on at IDOH to inform our prevention efforts. Samples are run through the Axis Toxicology's base panel, and then completed toxicology reports of decedents are shared with the Indiana Department of Health for review. These reports can reveal substance or metabolites that were found in samples collected from decedents, and then can be used to identify trends in substance use and within the drug supply. Some of the noteworthy emerging substances throughout 2023 were xylazine, bromazolam, metonidazine, and protonidazine, but xylazine was the most common, followed then by bromazolam. The Marion County Safe Syringe Access and Support Program provides free sterile syringes and collects used syringes from people who inject drugs to reduce the risk of infectious disease. The Indiana Department of Health Laboratories conducts drug analysis of residual content of used syringes, which then can detect new substances in the drug supply and then enable prevention services to advise and adapt strategies. In December 2023, of the syringes tested, 71% included a combination of fentanyl and cocaine, 67% included a combination of fentanyl and xylazine, and 64% included a combination of fentanyl and methamphetamine, which just kind of, again, complements some of the things that have continually been said throughout the day. And this is something that I know that the Indiana Department of Health is really looking to expand across the state. So we've been really lucky to see it be really beneficial in Marion County and really provide us with amazing information and data. And then more recently, in March 2024, the top 5 substances present in syringes tested included fentanyl, 4-ANPP, methamphetamine, cocaine, and xylazine. And then again, information like this is just really important to help provide us with information about the drug supply and better target treatment and response. And so to kind of round all of this up for you all, I wanted to kind of touch on some of these emerging drugs and a little bit more about them. So one that we're hearing a lot about is xylazine. Xylazine is a non-opioid agent that FDA originally approved in 1972 as a sedative analgesic for use in veterinary medicines. This is not approved for use in humans. Its signs and symptoms of acute xylazine toxicity may include central nervous system and respiratory depression, hypotension, bradycardia, hypothermia, meiosis, or high blood glucose levels. Acute and repeated exposure to xylazine is associated with clinically significant harms. It can delay the diagnosis and management of polysubstance overdose, and it is also associated with severe necrotic skin ulcerations and interfering with successful treatment of opioid use disorder. Repeated exposure of xylazine may also result in dependence and withdrawal. What we know about xylazine thus far is that it's usually injected, although it can be swallowed or sniffed. It has been primarily identified in combination with both heroin and fentanyl, which kind of, again, complements some of the things that we've heard about today with heroin kind of being fentanyl. And stimulants are something it's also been found with, so combined with methamphetamine and cocaine. And then reports from social media and news outlets suggest that xylazine-containing products may be sold under street names Trank Dope, Sleep Cut, Philly Dope, and Zombie Drug. And just want to reiterate here that even though xylazine is not an opioid, it is always important to utilize naloxone if an overdose is suspected, because as we kind of have talked about, that a lot of times xylazine is combined with opioids, and so we can address the opioid part, and hopefully then by the time that has happened, providers will be there to further assist. Another drug that we have heard about within Indiana is pyrrolidinoadenitazine. It is also known by the street names Pyro M30. And this substance is a powerful synthetic opioid, about 10 times stronger than fentanyl and between 1,000 and 1,500 times stronger than morphine. This substance has been detected in counterfeit drug product within Indiana. And pyrrolidinoadenitazine has been confirmed in 21 blood samples and 1 urine sample from 21 postmortem cases, and 17 of those were within the United States. And in all of those cases, additional substances were found in conjunction with pyrrolidinoadenitazine, including fentanyl and benzos. And then the reported effects include euphoria, drowsiness, itchiness, nausea and/or vomiting, and difficulty breathing. And similar to other opioids, pyro may cause fatal respiratory depression in the person who has ingested the substance. And because it is an opioid, again, naloxone can be used to reverse this as an overdose. And then one more substance I want to kind of bring to your attention is bromazolam. Bromazolam is a novel or designer benzodiazepine, and it has been found on the street under other names such as XLI-268, Xanax, fake Xanax, and dope. Bromazolam is frequently reported in combination with other drugs, and most often in combination with opioids, specifically fentanyl. And then the drug has gone from 4% of the overall novel or designer benzo supply in 2021 to 73% of the supply in the first 6 months of 2023. And emergence comes around the time that some of those similar drugs were temporarily placed on the Schedule I Controlled Substance Act in December 2022. Like other benzos, it can have the effect of loss of coordination, drowsiness, dizziness, blurred vision, slurred speech, muscle relaxation, respiratory depression, amnesia, or death. And as opioids are present in cases of overdose in which this substance is present, naloxone should be administered to reverse the effects of any opioid that may be present. So in conclusion, the evolving nature of the opioid epidemic has further reinforced the significance of surveillance, utilizing overdose data sources across public health, healthcare, and then public safety. Surveillance of fatal and non-fatal data sources is critical in monitoring for trends in overdoses and identifying emerging substances. And we utilize this data to recognize anomalies and disparities in overdose data, which allows us to collaborate with partners and stakeholders across the state to inform drug overdose response and prevention efforts. So with that, does anyone have any questions? If not, feel free to email me or my colleague, Allie. She is our drug overdose prevention epi, and she is also able to answer some questions about some of our data sources as well. Yes. No, utilizing naloxone will not hurt the individual. So we always encourage, even if it's a suspected overdose, just go ahead and administer naloxone. And it's good in the meantime. So typically we encourage, utilizing naloxone, then calling 911. And then when the medical providers do arrive, they can do further assessment and determine if the individual needs to go to the hospital or whatever that may look like. A lot of times we do see that individuals will need multiple doses of naloxone. So yeah, just something to keep in mind. Thank you.
Thank you, Shelby. Next, I would like to introduce our final keynote speaker, Dr. Ashlyn Burns, and I believe there's a special cause of her recognition as she just completed her PhD in Health Policy and Management at the Indiana University Richard M. Fairbanks School of Public Health and is getting ready to start a postdoctoral fellowship with the Indiana University School of Medicine in the Department of Psychiatry. She is a nationally registered emergency medical technician and health services researcher. Her research primarily focuses on access to implementation of behavioral health crisis care, as well as associated patient and population health outcomes. May everyone please welcome Dr. Ashlyn Burns.
Hello, everyone. Excited to be here today and to share a little bit about my research on behavioral health crisis care services with you. First and foremost, I'd like to acknowledge and thank all of my co-authors and mentors on this work who are listed here on this slide. And I would also like to thank the Agency for Healthcare Research and Quality for funding this research, and acknowledge the Substance Abuse and Mental Health Services Administration as the organization that maintains the database used in these studies I'm going to be presenting today. So I think there are many folks here who may be experts in crisis services, but I also think there may be some individuals who are new to this area. So I want to spend a little bit of time just talking about what a behavioral health crisis is, and noting that a crisis looks different for every person. But in general, it can be described as an acute state related to a mental health or substance use disorder that requires urgent attention. 1 in 8 emergency department visits and up to 15% of all 911 calls involves a behavioral health crisis. And importantly, rates of ED visits related to behavioral health have been increasing at a much faster rate than overall ED utilization. We've also seen rises in anxiety and depression since the onset of the COVID-19 pandemic that are coupled with delays in accessing care. In 2020, more than 12 million adults in the US reported serious thoughts of suicide, and among individuals who access mental health services, more than 17 million reported delays or cancellations in accessing care. So in light of these increasing needs, it's more important than ever to ensure access to behavioral health services. It's also important to ensure access to care because individuals who seek care in the ED for a crisis often do so because they feel as if they have nowhere else to go. Poor access to behavioral health services is particularly concerning for low-income, minority, and rural populations. And under EMTALA, which is the Emergency Medical Treatment and Active Labor Act, EDs must provide services to individuals experiencing an emergency regardless of their ability to pay. And this often means that the ED serves as a safety net for some of the most vulnerable individuals because it is one of the only fail-safe points of access to care in many communities. However, this is problematic because EDs often are not equipped to meet the needs of individuals who are experiencing a behavioral health crisis. Individuals with behavioral health needs desire quiet, safe spaces, strong patient-provider communication, and personalized care. And yet, providers within the ED describe this environment as loud, fast-paced, and overstimulating with little privacy, and that's not conducive to stabilizing an individual in crisis. As such, many individuals who have used the ED for behavioral health crises have reported feeling stigmatized and discharged without anticipated treatment. This means we have patients who are not getting their needs met, which leads to poor patient outcomes, repeat ED visits, longer stays, and overall higher cost of care. Patients with behavioral health needs also experience especially long wait times in the ED, and this is due in part to workforce shortages, workload demands, overcrowding in the ED, and limited training among ED staff in terms of managing patients with behavioral health needs. A few years ago, I was trained as an EMT, And so I had some clinical experience in the emergency department and also volunteered there for a while. And I saw some of these challenges firsthand. And it really made me wonder how we could improve emergency services for individuals who are experiencing a behavioral health crisis. One strategy or alternative to the emergency department is behavioral health crisis care, which is recommended as a best practice to meet the needs of patients. Behavioral health crisis care services may be offered by a variety of different organizations, including hospitals and mental health treatment facilities. And in 2020, SAMHSA published national guidelines for behavioral health crisis care, including a toolkit to help support implementation of these services. And the way that SAMHSA defines crisis care is that it should use a no wrong door approach, meaning that crisis services are for anyone, anywhere, at any time. And a comprehensive and integrated crisis network is truly the first line of defense in protecting public safety and preventing loss of lives. There are 3 core components of a crisis system, and these include crisis call centers, coordinating in real time, mobile crisis response units, and crisis receiving and stabilization programs. In other words, as I think you've heard throughout the day from several other speakers, a comprehensive crisis system should include someone to call, someone to respond, and a safe place to go. Ensuring access to all of these components of care and ensuring that systems are comprehensive is incredibly important to ensure that individuals are navigated effectively and efficiently to needed services. So I'm going to be presenting findings from 3 studies today, and I don't have enough time to go into a lot of detail about each of these, but I just want to give you a sense of what we did and highlight the key findings that have implications for the development of a crisis continuum. So to begin, I'm going to talk a little bit about the national availability of behavioral health crisis care services. So tying this back in with SAMHSA's best practices, there are 6 types of crisis services that are included in SAMHSA's best practice guidelines and are also measurable using the data sets available from SAMHSA. And these include mobile crisis teams, on-site crisis stabilization, walk-in services, crisis intervention teams, peer support specialists, and suicide prevention services. And so for this first study, we used a cross-sectional design, meaning we looked at the availability of behavioral health crisis care services at just one snapshot in time. And this is based on data reflecting 2021 and was conducted at the facility level. So it includes over 9,000 mental health treatment facilities across the US, which is pretty representative because we use the data from the Behavioral Health Treatment Locator tool, which is informed by SAMHSA's National Mental Health Services Survey. And this is a nationwide survey that has over a 90% response rate. So nearly all mental health treatment facilities are represented in this database. And so to highlight just a few of the kind of descriptive findings in terms of service availability, this here shows the number of mental health treatment facilities in percent that offer each type of service examined. And the key takeaway here is that only 6% of all mental health treatment facilities in the US have adopted comprehensive behavioral health crisis care services, meaning that they offer all 6 of the services that I mentioned that are listed here in this table. And additionally, meaning that they accept patients of all age groups, because as I noted from SAMHSA's definition, crisis services are for anyone. So to be considered truly a comprehensive facility, then they would need to offer all of these services and accept patients of all ages. And then in terms of individual services, we found that suicide prevention services were the most common, offered by almost 70% of all mental health treatment facilities, whereas mobile crisis services or offsite care was the least common service offered, with around 20% of all mental health treatment facilities having mobile services. And this here is a map that shows the locations of all of the comprehensive behavioral health crisis care facilities that have adopted all of these best practices. And you can see that they're kind of scattered across the US, with some states tending to have many facilities and others having very few to none that offer comprehensive services. And I just want to note again that this is based off of 2021 data. And given all of the transformations and implementations of new services and recently, it is possible that more facilities have adopted services since this graph was created. And so that's kind of a overview of the key findings from study 1. And then the next study, I wanted to learn a little bit more about the characteristics of the communities that have behavioral health crisis care services, given that we found so few have adopted comprehensive care, in order to see how these communities differ from those who may have some services available but have not been able to fully adopt comprehensive care. And so this was also a cross-sectional study just at one point in time. And rather than looking at the facility level, this study looked at the county level and represents all 3,142 counties in the US. And so we're looking here at the availability of comprehensive crisis services within the county. And again, 2021 data. And so for this study, in addition to the data set from SAMHSA that I mentioned already, we also pulled in some data on the geographic location type from the USDA and some county health indicators from the county health rankings and roadmaps and the area health resources file. And so I know there's a whole bunch of numbers on the screen right now, and I want to kind of break this down to share with you a little bit of what we found here and what we're looking at. So some of the community characteristics that we looked at for this study were reported rates of mental distress as a measure of the community's need for behavioral health crisis care services, median household income, and the percent of individuals who were insured as a measure of the community's ability to pay for services, and then mental health providers per capita as a measure of the available workforce, and geographic area in terms of whether the county was rural or urban. And so for those of you who are interested, these are results from logistic regression models. So the numbers presented here in the table are adjusted odds ratios with 95% confidence intervals. But to kind of just simplify this and tell you the key points here, the two things that were really significant and have implications are that urban communities were significantly more likely to have comprehensive services compared to rural communities. And we found here this was true in the case of both comprehensive services as well as across every individual service examined, that the urban communities were more likely to have adopted services, which is not really a surprising finding given that urban communities tend to have more resources and services available. And then the second key takeaway here is that communities with more mental health providers per capita were also more likely to have comprehensive services, again, as well as all individual services examined. And this is also not a surprising finding given that organizations can't really expand or adopt additional services if they don't have the workforce and capacity to support those services. And so this really tells us the importance of investing in enhancing the capacity of the mental health workforce in order to increase access to care. And then moving to the third study, after looking at availability of crisis care services and the types of communities that have these services, I wanted to learn whether availability of behavioral health crisis care services is actually associated with changes in emergency department utilization or not. And so to recap from the background and introduction, emergency department overcrowding and lengthy patient wait times are longstanding challenges that compromise quality of care. And we know that untreated behavioral health needs contribute to a large portion of ED visits that are largely considered to be preventable. And while behavioral health crisis care has been touted as an alternative to the emergency department, prior to this study, there was very little empirical evidence that establishes whether or not access to behavioral health crisis care services actually reduces ED utilization on a population level. And so the objective of this third study was to assess changes in ED utilization associated with availability of behavioral health crisis care services. And in addition to using the data set provided by SAMHSA, this study also used data from HCUP's state emergency department databases. And this is visit level ED data that includes primary diagnosis as the visit reason using ICD-10 codes. And so that's what I used to measure whether the ED visit was related to a behavioral health need compared to another reason. And so for this study, we use longitudinal data. So we're now looking across several years from 2016 to 2021 and looking at zip codes from 5 states. So the states represented in this study were Arizona, Florida, Kentucky, Maryland, and Wisconsin. And in selecting these states, we were limited by a few factors. Not every state reports data to the state emergency department databases. And then we required that the states included in the study reported data across all years of the study period. And then finally, this data is not publicly available. It had to be purchased using grant funds. And so we selected states carefully in order to maximize the number of states we could include given the budget for this study and tried to ensure geographic representativeness of states from different areas within the US. And so there were a total of 6,012 zip years represented in this study. And so in the first 2 studies, I was looking at availability of services as an outcome, and I'm now looking at availability of services as the independent or predictor variables. So for this study, I created an indicator for 4 different types of crisis services, including walk-in stabilization, crisis intervention teams, peer support specialists, and suicide prevention. And these were the only 4 services that were reported across all years of the study period. So I wasn't able to look at all 6 of the services I mentioned before. So for the 4 services that were included, I first created an indicator for each facility, indicating whether or not they offered that service in a given year. And then across all facilities, that was aggregated to the zip code level to create a count of the number of facilities in the zip code offering each service in a given year. And this allowed us to identify when a zip code first had services become available or had an increase in service availability. So we could look at changes in ED utilization before and after that change in service availability. And so the dependent variable or outcome of interest here, looking at ED visits, is ED visits that were related to a mental, behavioral, or neurodevelopmental disorder. And this is a group of ICD-10 codes that are generally considered to be preventable. And we looked at the rate of visits related to some type of behavioral health need per 100,000 population. And then again, for those who are interested, we did a linear regression model with zip code and year fixed effects and accounted for clustering by zip code for our analysis. And so here I want to show this graph that shows changes in overall availability of behavioral health crisis care services throughout the study period. So each of the 4 services are across the bottom, and the bars show you from 2016 to 2021 the total number of facilities offering each service type. And you can see, especially when looking at walk-in stabilization and crisis teams, that they tend to fluctuate up and down from year to year. So in some years, we have facilities that offer services or new facilities that open, whereas in other years, we have facilities that either close or scale back services. And then you can also see here that in general, we've seen an increase in availability of suicide prevention services over the past few years, as well as increases in the availability of peer support specialists. And so these numbers here are the findings from the model looking at the relationship between availability of behavioral health crisis care services and behavioral health related ED utilization. And the kind of main finding here that is statistically significant is we found the availability of walk-in crisis stabilization services was significantly associated with reduced behavioral health related emergency department utilization. Whereas the other 3 services examined in this study were not significantly associated with any changes in ED use. And so what does this number really mean, or what does this tell us? So to interpret the coefficient from this model, what this really means is that for every additional facility that offered crisis stabilization services, we saw a 2.8% decrease in the mean or average rate of behavioral health related ED utilization. And given the overall rate of ED utilization for behavioral health during the study period, this equates to about 36 visits per 100,000 population. And applying this to the total population size across the states represented in this study, this translates to an estimate of just over 1,500 ED visits diverted per year. And so I also tried to look at estimating the cost savings of these diverted ED visits. And I want to note a disclaimer that these are just kind of crude, rough numbers here, and we really need for future work a more in-depth cost effectiveness and cost savings analysis, but just trying to base some estimates off of what we knew already. And so looking at 2017 estimates, the average cost of an ED visit related to behavioral health was $520, whereas estimates from CCBHC demonstrations have shown that crisis stabilization at one of these facilities can be around $200. And so the difference here of about $320 saved for every ED visit diverted from an ED to a CCBHC or a walk-in site, and applying that across the 1,500 ED visits diverted in this study suggests that the addition of walk-in services offered by a mental health treatment facility can save almost $500,000 in diverted ED visits. And I do want to take a moment to note a few limitations of this study. So we were limited to the information available in SAMHSA's directories, which requires that the organization reports any changes in service availability. So this is one of the most comprehensive resources available and is generally updated monthly, but again requires that the organization report those changes in order for them to be reflected. As I mentioned, in the first 2 studies, I looked at 6 services, but I could only measure 4 of those 6 services in the 3rd study, partially because mobile crisis teams was only reported by SAMHSA beginning in 2020. So I couldn't look back far enough to measure changes related to availability of mobile crisis teams, but I think this is an important area for future research to follow. And then just to recap again, the key takeaways across this body of work. We found that access to behavioral health crisis care, specifically walk-in crisis stabilization services, may help keep patients out of the ED. And yet, looking back at studies 1 and 2, we also found that access to these services is very limited and fragmented across the US. Despite the potential for these facilities to increase access to more patient-centered care, while also saving costs. And some of the factors related to this from study 2 were, again, the workforce shortages, and then we also saw the disparities in rural areas, which really indicates a need to invest in developing the mental health crisis care infrastructure, particularly in rural areas, to reduce disparities in access to services. And thank you again to everyone for listening, and I will take any questions. Yes. The first study that I presented is published in Psychiatric Services, so that is available. The second study is just was accepted for publication, so that will be out soon. And then my third study has been is being revised and resubmitted right now to a journal, so that one's not out yet. But I'm happy to share the links to paper 1, and when paper 2 is available, I can also share that. Distinguish between whether the service was offered like through telehealth or not. It's just whether the facility reported offering each type of service. So from the data, I can't necessarily tell if that service is in person or a telehealth service. Thank you.
Thank you, Dr. Burns, and congrats once again. Lastly, I would like to call up another colleague of ours and partner in Jeannie Bellman from Indiana Division of Mental Health. Jeannie is the Assistant Deputy Director of the Bureau of Substance Misuse Prevention and Mental Health Promotion at the Division of Mental Health and Addiction. Ms. Bellman has a Master's of Social Work degree and previous experiences conducting outcomes evaluations for child serving agencies. May everyone please welcome Ms. Jeannie Bellman.
Thank you, Malcolm, for that introduction and for keeping us moving so smoothly throughout the day. I would also like to thank all of the wonderful speakers that joined us today to share their knowledge. I know I learned a lot, which I find I always do in this field. So thank you again. At its core, the SEOW functions to collect, analyze, and report on data around substance use and mental health. The SEOW uses that data to make recommendations to DMHA and state agencies. And the SEOW also aims to increase access to data as well as use of data by communities. In an effort to better understand how the SEOW can benefit the work of communities, DMHA will be sending out a survey to community agencies in the coming weeks. If you saw the QR code that was posted earlier, you had an opportunity to also complete that survey. If you missed the QR code and would like to complete the survey, please see one of us and we can get that to you. And the purpose of that survey is really to find out how the SEOW currently aids the work of communities, but then also, and perhaps more importantly, what we can do differently to better meet the needs of communities. So what kinds of data do communities need? And then what kind of resources and products could we create that would then help the communities be able to use that data better? We know that the use of data is incredibly important, both in planning, but also in seeking out funding for the work that you're doing. Again, thank you all for coming to the 2024 SEOW Annual Symposium. We are very pleased and proud to have you all here. Please drive safely on your way home and have a great weekend. We hope to see you again next year. Malcolm, do you have anything? And I'll pass it back to Malcolm real quick.
As Jeannie's said just now, here's that QR code if you would like to take that survey. I just wanted to quickly thank everybody, all of our guests for joining us on this lovely Friday afternoon. You could be anywhere, but here you are listening to these amazing speakers. And thank you so much to all of our speakers. A special thanks. I know I was bombarding you all with my emails these past couple of weeks. So thank you for your patience and your support in coming out today. I also would like to thank, of course, DMHA, Jeannie, Dr. Minnick, Joyce, your team for your help today, as well as the CYRA team, Dr. Rupalanchi, Dr. Devraj, of course, my colleagues, Jason, Brandon, everyone who made this event possible today. Thank you so much, our registration team outside and the event planning team as well. Thank you. May you all have a blessed Friday and a blessed weekend and enjoy. Thank you for coming out.